Moving on to hip dislocation. This question asks, a 26-year-old female presented to the emergency department with an injury seen in the x-ray on the right, which is a posterior dislocation of the hip from an awkward fall while intoxicated. She undergoes closed reduction and repeat radiographs are seen, and what you're asked to take from that is that that's a concentric reduction. And it asks what the most appropriate treatment appropriate treatment is next. And as we previously mentioned with the femoral head fractures, CT scan following a dislocation is the most appropriate next step to assess for joint reduction, congruency, and any associated fractures or loose bodies that may be present. Again, hip dislocations are relatively rare. High instance of associated injuries with these. Commonly, the labrum capsule is torn, ligamentum teres are torn as a result of the injury. Classification, I'm not sure you're likely to see many questions with this other than those that are either simple, pure dislocation, relocation without bony fracture. Those that are complex are associated with fracture of the acetabulum or the proximal femur. The mechanism of injury, most commonly these are posterior. There's a axial loading for a posterior dislocation, adduction and flexion of the hip will often result with loading on the distal aspect of the femur. And as we mentioned previously, ipsilateral knee injuries can be present up to 25% of the time. Anterior dislocations can occur. You are familiar with these as either a pubic or an obturator dislocation. The inferior dislocation is the obturator dislocation that occurs when the hip is abducted and flexed and then loaded, and a superior dislocation, the hip is abducted and extended, leading to a superior suprapubic dislocation, quite uncommon. These anterior dislocations are often associated with an impaction injury to the femoral head, and again, just like posterior dislocations, a CT scan is recommended for these once the dislocation occurs. Because the dislocation can occur, because they can occur in association with an impaction injury, it may be difficult to relocate these. The initial treatment for these is emergent closed reduction, and time spans that exceed beyond 6 hours have been associated with a higher risk of avascular necrosis with this injury pattern. Irreducible patients that are eligible for operative reduction are those that have an irreducible dislocation, more commonly the anterior dislocations, and it should again be performed on an urgent basis. Closed reduction is performed with the patient supine and apply traction in line with the deformity. Post-reduction for simple dislocations, protected weight bearing is indicated. Again, once again, CT scan is recommended post-reduction. Looking at patients with complications following dislocation, up to 20% can have post-traumatic osteoarthritis. And femoral head osteonecrosis is seen in up to 40% and increases dramatically if there's an increased time to reduction of the dislocation.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.